You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 28, 2019. This week, medical reversals, conflict of interest in the cath lab, burnout in cardiology, changes to TAVR rules in the U.S., and a July 4th announcement. The first topic is medical reversals. Of the many problems in American medicine today, low-value care is amongst the greatest. My friend Vinay Prasad, an oncologist at Oregon Health Science University, and his team have worked hard to better describe this problem, mainly so that clinicians can more rapidly de-adopt ineffective practices. Their new paper, published in the open journal eLife, adds to their previous work on medical reversals. And a medical reversal is a subset of low-value care defined as a practice that's been found through RCTs, randomized controlled trials, to be no better than a prior or lesser standard of care. In 2013, Prasad and Saifu and others published a list of 146 practices that were overturned by RCTs. At the time, they looked only at the New England Journal of Medicine. But this paper extends that work by searching RCTs from JAMA, Lancet, and New England Journal. Their search identified slightly more than 3,000 RCTs. They then excluded novel therapies, or those therapies that were described as positive or inconclusive findings in the RCTs, and ended up with 396 medical reversals. That is 13% of the total number of trials they found. Now, one new change from their past work is that when they found a medical reversal, they also searched for a systematic review of that therapy. And in their paper, a systematic review confirmed the reversal in approximately half the cases. Now, finding a systematic review is important because one of the challenges in defining a medical reversal is the interpretation of the results of a trial. For instance, Prasad's team may say it's a reversal, but experts in the area may say, no, the trial results do not actually reverse the practice. So, heart disease was the most common medical category of reversal, followed by public health and preventive medicine, and then critical care. The key feature of their eLife paper was a 400-page evidence table in which they listed all of the reversals, and this is a massive document. It took me about a week to go through it. I focused obviously on cardiology practices, but also I couldn't help see many of the non-cardiology reversals. The authors say that they'll publish this table on a website that allows users to sort through the reversals, and that'll be a really good thing because the document is pretty hard to get through. Some examples in cardiology. Of course, the biggest reversal in my career is yet to be de-adopted. That is the use of stents and PCI for patients with stable coronary artery disease. Despite the COURAGE and BERRY 2D trials, as well as numerous meta-analysis, and most recently the ORBITA trial, PCI for stable coronary disease, and more broadly the search for ischemia proceeds in earnest. Then you have the BVS or dissolving stent debacle. We still do thrombus aspiration during STEMI, despite RCTs showing it is ineffective. The balloon pump for cardiogenic shock and high-risk PCI, this was a reversal. Off-pump CABG, pacers for vasovagal syncope. When I joined cardiology practice here, this was common. At least this has been mostly de-adopted. A really common one that I see almost every day is rhythm control for AFib after cardiac surgery. We still give lots of IV amiodarone to treat AFib after heart surgery, even though the Gilinoff et al. Study showed that antiarrhythmic drugs was no better than rate control. And in electrophysiology, the STAR-AF2 trial reversed the common practice at the time of doing extra ablation besides PVI, for instance, doing linear lines and cath ablation during AFib ablation. STAR-AF2 showed that simple PVI led to similar results. Now, some of the reversals outside of cardiology are breathtaking and worth taking a look at. Sepsis therapy has seen many reversals, such as goal-directed care, protocol-based care, albumin replacement therapy, all shown ineffective. Well, think of the harm that we have done to people with sepsis. Epidural injections of steroids for spinal stenosis, ineffective. I did not know that universal glove and gowns precautions for resistant bacteria in the ICU was ineffective. and even ICU checklist. An RCT found that the use of a multifaceted quality improvement intervention with daily checklist did not reduce mortality rates in ICUs compared to routine care. Chlorhexidine bathing and healthcare-associated infections, ineffective. Thyroid hormone replacement for older adults with subclinical hypothyroidism. And how about this one? Avoiding early peanut consumption to prevent peanut allergy. That was a medical reversal. Now, I'm working on a column on this important study. Patrice Wendling has a beautiful recap of it, and I especially like the comments from academic cardiologist Robert Ye, who lauded the fact that cardiology had the most reversals. Ye noted that cardiology has a large denominator of therapies, which is a good thing. And we as a field have been willing to do the hard work of testing our therapies, which is also a good thing. Here are some quick thoughts I had going through the 400 pages of low-value care. First, do not let the term medical reversal hide what is really going on here. Namely, we do things to people. We cut them, poke them, medicate them, all with the aim of helping. But then, sometimes further study proves that we were actually providing no benefit and in some cases doing actual harm. And to me, that is sobering. And it leads me to find 3 important take-homes from this paper. First, people who care for patients must become better judges of evidence. It's so damn easy to be fooled. Early in my AF ablation career, I was duped. I bought into the expert opinion that more ablation was better, and it was not. I see this happening to my younger colleagues now with left atrial appendage occlusion, and it's already happened with TPA and stroke. Second, clinicians must always fight against hubris. Though there is a role for fast thinking in the setting of a crashing patient, most of medicine can be practiced slowly. We need to get far more comfortable with uncertainty. For instance, when a prescribed therapy merely makes sense, all involved parties should be very cautious. For instance, I love it when patients ask how sure I am about something. No matter how rushed I am, this question makes me stop in my tracks. Third, this sort of descriptive data ought to make us question our action bias. If we don't know what to do, doing less, I think, decreases the odds that the next generation of doctors will consider us fools. Do you ponder what the future generations will think of our therapies? I often do. Next topic is conflict of interest in the cath and EP lab. The Yale research team led by Jephthah Curtis is doing important work with the Open Payments Program. Their latest study looked at patterns of industry payments to lab directors at top 100 hospitals. Among the nearly 200 laboratory directors included in the study, only 7 IC directors and 4 EP lab directors received no payments in 2017. Let me repeat that another way. 94% of lab directors received money from industry. Nearly 1/3 of cath lab directors and nearly half of EP lab directors received payments of $10,000 or more, and payments to directors were far substantially greater than normal interventional and EP docs in the same zip code. Now, okay, I know what you're thinking. Both interventional cardiology and EP are practices that require collaboration with industry. But directors of labs often have significant influence over device choices, and these dollars can affect these choices. And if it didn't, industry would not make these payments. I agree with Dr. Rita Redberg, who said in a news story that she thinks professional societies should prohibit doctors from relationships with industry when they make purchasing decisions for their hospitals. But perhaps better than prohibition would be that the directors just said, no, this isn't right, I'm not going to have this conflict of interest. Now, in the news story, interventional cardiologist Dr. Adam Salisbury pushed back. He rightly said that not all payment for services are dinner talks. Some could be non-CME educational courses, noting that their hospital has an active center for CTO PCI, that's chronic total occlusion PCI, and they often host physician training courses. But there you see the issue, don't you? Industry wins every way here. They get in good graces with a busy hospital. The dollars support the hospital fellowship program. Fellows feel good about the support. And the best part is docs from all over the country come to learn how to use more industry products. But perhaps the health of Americans would be better off if the time and money spent on such non-CME programs went to critical appraisal of the evidence, especially for procedures like CTO, PCI. Here we have an expensive, risky intervention that has obvious benefits for the hospital and doctors, but little compelling evidence that it helps patients. I'm growing increasingly convinced that you can practice EP or interventional cardiology without taking any money from industry. Next topic is burnout. Dr. Laxmi Mehta and co-authors have a special report in JACC looking at burnout and career satisfaction. Their study presents results of the third Professional Life Survey. This is 10 questions regarding professional wellness. About 2,300 docs completed the survey. Bottom line, 1 in 4 American cardiologists report being burned out, and another 49% cite being under stress and having less energy. As one would expect here, though, the upbeat, level-headed voice of reason, Dr. John Irwin from Texas, saw some positive news. He noted that the 25% rate of burnout is less than the 43% rate reported in the Medscape report on cardiologist lifestyle. Irwin noted that in days past, doctors spent time in the cafeteria or doctor's lounge discussing cases and bemoaning the bad things that may have happened. This, he says, was therapy, and he's right. Nowadays, though, there is a lot less of this. People are too drilled out. Now, data entry is one issue, but the other is the drive to see more patients faster. I highlight this survey because it's a vital issue. Now, let me speculate a bit about a possible clue in the data. Burnout appears to peak among mid-career cardiologists, those with 8 to 21 years in practice, compared with fellows in training, early career, or late career cardiologists. Here's a possible explanation. New people, they don't know any different. They have never been independent, and they don't know how that gives you a say in how a hospital runs. They have never written a physical exam as unchanged because it was unchanged. And late career docs have what Nassim Taleb calls the Lindy effect, basically survivorship bias. Late career docs have found a way to be late career. They can see the end of their career, and they can call it quits if it gets too bad. Having an escape makes the nonsense easier to withstand. But the mid-career people, they have to keep working. They have kids in school, mortgages to pay. But also, mid-career people know how medicine used to be. Perhaps they are attached to how it was before docs lost their voice. Now, an attachment always causes suffering. The question, though, is how to fix this, and surely John Mandrola has no quick fix. Heck, I often struggle with the metastasis of nonsense. But I was struck by what Eric Tobel said in a conversation he had with Russ Roberts on the Econ Talk podcast, and I'll link that in the show notes. Tobel said the only way docs were going to bring back meaning and empathy to medicine was to unionize. Now, I know that sounds drastic, but one thing that I have constantly witnessed throughout my career is that doctors just don't stick together. If we did, we'd have influence, but we don't. Different doctors have different goals. Some docs like the EHR, for instance. Some like being employed. And then there are always the fights about salary. This means we don't speak as one group. And to me, our inability to resolve our internal conflicts have led to our slow and steady transformation from professionals to providers. Final topic today are rule changes in TAVR. CMS, the Centers for Medicare and Medicaid Services, otherwise known in America as the rulemakers, have finalized an update to the national coverage decision for transcatheter aortic valve replacement. The big news heard around my lab this week about this story was just two words, and they were one surgeon. That's because until now, elderly patients with aortic stenosis who were clearly ideal for TAVR rather than surgery had to formally see two cardiac surgeons so the surgeons could check off the cardiologist's decision. Now it is just singular, one surgeon, and this is a good change. Well, 3 other aspects of the document which have been lauded by ACC and device makers are: 1, the care of the patient stays under the guise of a heart team. 2nd, the hospital must participate in a legitimate registry that importantly includes enrolling consecutive patients. 3rd, the team and the hospital must have adequate infrastructure and volume. But this is key, there is a lower yearly minimum of cases. So a few comments. First, on the team approach to medicine. Now, this decision cuts both ways. Yes, having multiple disciplines involved can be a good thing. But is this really better than one dedicated doctor who really knows the patient? I mean, maybe, probably, but perhaps, think about it, our deference to all things team-based may someday become a medical reversal. One change to the team-based decision-making that I would like to try out is to have patients or a patient's family attend the team meeting. Now, on the matter of the registry, this is simple. It's a good idea. 2 thoughts on volume requirements for TAVR. Yes, of course, everyone knows it's obvious that high-volume experienced operators will do better at TAVRs. This procedure takes feel and skill and experience. But the problem is that when you set numbers to be done, you incentivize people to get to that number. And this, of course, affects patient selections in hospitals that are close to the cutoff. Second, I'm uncomfortable with lowering the requirement of cases in the name of improving access to the procedure. TAVR underuse in minority groups and in patients from rural areas is definitely a problem, but is the correct answer to expose these patients to less skilled operators in hospitals? Once again, expanding the number of TAVR centers helps doctors and industry, but will it help those patients? American cardiology is already way too supply-driven. I can't help think a better way to provide care, again, is the Canadian model of having small numbers of super high-volume centers with high-volume operators, and those places do the majority of complex interventions, and then find better ways to get patients from these rural areas and minority groups to these centers of excellence. So that's it for this week in cardiology. And remember, next week is Independence Day here in the U.S., so my family is in town, and I'll take that week off and come back the week after. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please tell a friend, consider subscribing and writing us a review so that others can find us. Until 2 weeks, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.